Okay, so we're going to talk about creating a mobility plan. And I also added with the older adults because it's not just for them, it's with them. And we'll emphasize that as we go through here. So today, I just want to talk about the overall physical activity recommendations for the older adults, as well as the holistic and 5M approach to the assessment of physical activity and what that involves. I know we talk a lot about the 4Ms, but I'm going to encourage you to think about the 5th M of multi-complexity that we'll talk about as well. So that's where the 5th M comes from. We'll also look at barriers and facilitators to physical activity and then apply the 5Ms of age-friendly healthcare to a case example with the mobility plan as the goal here. So staying active, if we look at the overall trend of where we're at with the World Health Organization here, they rate physical inactivity as the 4th leading risk factor of mortality. And I think a lot of us in healthcare know this. We know the importance of it and how it can prevent so many other comorbidities. And I think in general, the public also knows the importance of it. But today I really want to get down to what we can do to help facilitate that participation, because it's not just about recommending, and we'll talk about that. But we need to do so much more to try to improve activity. Overall recommendations by the CDC, most of us might be pretty familiar with this, but aerobic minutes would be 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity. And we'll talk about that intensity level and the importance of that, both with aerobic and strengthening activities. But the aerobic activities spread throughout at least 3 days in the week, sometimes 5 days if we need to have shorter bouts of activity. Strengthening. This is one of the pieces I think that in the older adult we really need to emphasize, and is coming out more in the research of how important it is. And the recommendation is 2 times a week for that. And both the aerobic and strengthening recommendations here are fairly similar to what is recommended for younger populations as well. But I really want to emphasize the flexibility and balance component is an addition for the older adult. And incorporating at least 1 day of balance activity and ultimately adding up to 50 hours is really where you're going to have the most benefit and the actual change in the ability to balance better. And we'll talk about some of the FIT principles in our case as we go, but again, really highlighting the intensity of that and education for our patient on what that means. So if we look at strengthening in particular, there's a couple articles here. Fragala, that one is a position statement from the National Strength and Conditioning Association. And it really, if you are interested in some excellent recommendations, they have evidence-based practice recommendations for the older adult, really highlighting some of the specifics that we can look at with that population, as well as McLeod. This one looks at the age-related chronic disease and the importance of resistance training and how that can be just as effective as the aerobic training. But again, I think it's a piece that we definitely need to emphasize in regards to slowing that atrophy that happens with aging, that sarcopenia, as well as osteoporosis. Not just strengthening, but weight-bearing strengthening as well to really get those bones nice and strong. And then here, flexibility and balance. I think yoga and Tai Chi are some really excellent ways that you can combine that multi-component aspect of flexibility and balance. And if a person is not quite comfortable with that, you can break it down to individual. I like to do functional stretches, activities that you might do in your everyday, and incorporating the stretches throughout the day. But I also added here floor to stand transfers. These, I think, can be a very beneficial way to have your older adult work on ways to move. It's a good core strengthening as well. And if they are at risk for falls, it can improve their confidence so that they don't worry about getting back up if they do happen to have a fall. But there's many aspects of that. But flexibility and balance, definitely an important component for the older adult. So if we look at specific considerations when we're looking at the mobility plan, these come to mind. We do need to think about comorbidities and how that impacts them. Looking at their individual fitness level, you might anticipate that depending on the person you're working with, they may have never done a certain amount of activity. They've just done their daily activities and nothing more. So we really have to meet them where they're at and finding out where that level is for them. Along with that goes that readiness to change. Again, if it hasn't been a normal part of their routine, we really have to identify, are they at that level where they're ready to make a change, or do we need to help facilitate that? With our older adult, location of activity can be a very big component. It may be that they are unable to drive any longer, or maybe they do have the ability, they just don't feel comfortable any longer. So we just need to be sure that what we are recommending matches with what they are able to participate in. And there's been a lot of out there in regards to life space mobility as well. And this is the idea of looking at assessing the patterns of mobility over time. And there are actually measurement tools out there looking at function, their overall environment, different societal factors as well, that can give you more information just about actually predicting morbidity, mortality, and actual healthcare utilization as well. And so it can add to your assessment of looking at those aspects with their mobility plan. And fear. Fear can be a big component. It's definitely something to keep in mind and do an assessment of, because for one, if your older adult has not participated in any activity before, there may be a concern that they will hurt themselves, or that because they're starting something new that they'll get sore or not be able to continue doing the things that they want to do. But I think that's a big education piece. And also, again, meeting them where they're at and finding what works for them. So just to emphasize where we're at today, this looks at some of the statistics of how much activity our older adults are actually getting, and 91% of them do not get the recommended amount of physical activity. And when we look at strength training, only 8.7% of older adults over 75 do any sort of strength training. And I think it just emphasizes the point that this is our person who has lived their life, and you know, what they did earlier on in their life is going to impact later on as well. And so I really, one take home point I want is that we're not just treating our older adults. We need to be working with our whole population, starting these habits and behavior changes earlier as much as we can. And we'll talk about how to do that with any person as we go today. But it's a big goal to achieve, to try to increase this percentage of people who are meeting those recommendations. But I just want you to take a minute to think about this. This is Mr. Rogers. I think he has a lot to teach us, and not just in our younger years, but here he said, his quote is, "There's a world of difference between insisting on someone's doing something and establishing an atmosphere in which that person can grow into wanting to do it." And I think this really applies in this sort of situation when we're approached with attempting to help someone create a mobility plan. We talk about the recommendations. We say, you should do this, but do they have the atmosphere or the environment or the motivation to want to do that? And so I think that's really where we can gain a lot of perspective with this and with our patients to take the time to do this. So again, I really strongly believe we have to go beyond just recommending. We can't just say, this is what you should do, because 50 to 75% of health providers are not actually incorporating behavior change techniques into our practice. And I really do believe this is where it will make a difference in the actual change of incorporating that mobility plan into their long-term daily lives. And so we have to look at those barriers, a few of them that I already talked about, and actually creating that environment and the opportunity for them to be able to participate. And part of that goes into assessing their readiness to change. This document comes from the Exercise is Medicine website, and it's an excellent resource if you need any sort of a guide to help, even in the sense of education for your patient, or how to incorporate this into your practice. There's so many good resources there. I strongly recommend that, but this is just one of them. This is the looking at the readiness to change, the different levels of pre-contemplation where they haven't even thought about it, to contemplation, they're thinking about it, but maybe not really sure about how to go about it. Preparation is they are actually planning. Maybe they're making a schedule or getting exercise equipment. Action would be they're doing the goal that they've set out. But this action would be within the first 6 months. And then ultimately what we're shooting for, what the goal is, to get to that maintenance level where they're doing that physical activity for more than 6 months. And that's really creating that behavior change to maintain the physical activity. And adherence. I mean, I've worked in clinical care for 16 years, and I'm sure there's many listening who can attest to the fact that adherence is sometimes the biggest challenge to try and reinforce that change with your patients or the people you're working with. But it really is, it can take time to work through that process of readiness to change, but it really can be some very well spent time with your patients in looking at things like building self-efficacy, that confidence in what they're doing. providing that positive reinforcement, whether it's from you as a caregiver or from the family or other social supports. And a big one, especially with our older adults, is that comfort and reducing that fear in incorporating exercise or movement within their mobility plan. And just to provide some research on this, of incorporating that behavior change into an actual intervention. This study is out of the Netherlands, and it looked at older adults age 70 and older. And there was a control group of just the basic exercise protocol. And then the intervention group also completed the same exercises. There was no protocol. It was just kind of the standard of exercise throughout. But the intervention group, they incorporated more of these behavior change techniques. So motivational interviewing, you may have heard about. Really asking open-ended questions, engaging the patient that you're working with, empowering them to try to help facilitate that behavior change. Looking at SMART goals, so it's very specific, and making that meaningful to the patient. I think sometimes, we know that that's beneficial, but just being very mindful of that, I think, is important. And then having a shared decision making, having the patient or the person you're working with, having it very person-centered. And then systematic monitoring. I think this is something that I think we can all say, if we have somebody kind of watching over our shoulder, it can help facilitate that participation and continuation of the activity. And I think this could be a whole nother topic, but I think as our world with smart watches and smart monitoring and even AI into healthcare, this could help reinforce that in a lot of different manners. But like I said, that's a whole nother topic. But this intervention group, and actually both groups, they did have meaningful changes and helped to reduce the frailty within both groups. But the intervention group actually had the more significant change in the long-term benefit. So reinforcing that overall behavior change into that 6 months or greater, which is essentially what we really want, because we can't be there all the time. We need that change to happen and have it be long-term. So we're going to look at the 5 M's when we look at creating our mobility plan and the assessment. So I'm just going to touch on some of the pieces we'll focus on here, and then we'll move into a case application. So when we look at what matters, we first have to kind of see where are we starting, that individualizing to the person. So we need to look at where is the physical activity right now? How many minutes, how many days per week are they doing physical activity, looking at strength, looking at balance as well. Are they meeting those recommendations? If they are, great. We would move down into this yes column. So they are in that maintenance. So just encouraging them to stay there. But that's not often where we are starting. Often they are not quite meeting those recommendations. So then we say, do you have an intention to change any of that in the next month? So is there a short-term intent? Okay. Maybe they do, maybe they don't. If they don't, then we would go into more of that. Are you looking at maybe 6 months down the road? Do you intend to change? Maybe right now is not the best time. And so this will put them in different categories of what I was highlighting before, that actual behavior change. And you can see that where they land is really going to emphasize a different approach. And you'll see that with our case application as well. But I think it's important to identify that. Another tool you might find helpful is to look at what matters. And of course, this is one of our M's, but there is a what matters most structured tool. And this looks at different areas of life, including functioning, life enjoyment, and connecting. Sometimes it's hard for our patients to really put down or verbalize what matters most. They might just say, well, I just want to get stronger, or maybe they're not there, but it gives options where there's maybe different things like maybe thinking more clearly is important to them with function, or maybe dressing or bathing themselves is most important. There's things like enjoying life, traveling, or maybe just having quiet time to do nothing. So it gives them a variety of options there to try to prioritize what that is so we can learn more about them and incorporate that in their plan. It also looks into some religious and spiritual beliefs, cultural, racial, ethnic background, asking questions about controlling pain, how important these aspects are to them. Also input from family, because as we know, with the older adults, the family does tend to be more involved, but there can be competing values, you might say, between the patient, the family, the care provider, but this helps to emphasize where how much of that input the patient really desires. And then it also asks the question, which I think is very important, but definitely in our current healthcare environment, the quality of life versus length question. I think that often we're more focused on the length, but I think it's becoming more apparent that quality of life can be a very important aspect to our patient, but we don't know unless we ask the question. So it can help you identify the what matters more objectively. And then when we're creating the mobility plan, the mind is very important. So I highlighted the 3Ds here, especially because I think that often these can be missed unless we do a basic screen. So if we're in an acute setting, the confusion assessment method might be important to look at the delirium, but the mini cog is where I tend to go if I'm within my subjective finding things that maybe I feel like I need to explore a little bit more. And then also under the depression aspect, I think the PHQ-2 is, or the geriatric depression scale, both can be very beneficial just to do that quick screening, because mental health within our society is very important to keep in mind when we're working with any individual, but especially with our mobility plan, because that can impact their motivation as well. When we look at medications, I just highlighted here some common heart failure medications because the case we'll talk about later does involve heart failure, but looking at some of these medications like beta blockers, this is going to blunt the heart rate response. That's one of the biggest things I think about when I think about mobility. And so we need to be aware of those medications so we can modify how we are doing our assessments. And then diuretics, kind of the big thing that sticks out is that dizziness or even dehydration, because that can affect mobility. But keeping in mind the Beers criteria or the STOP criteria for monitoring the medications with the older adult, as we know, is very important. So when we look at the actual mobility piece of it, I'm recommending some pretty brief assessments that can be done. And this one is a short physical performance battery. It can actually be even broken down into separate pieces, but the full battery incorporates balance, gait speed, and a chair stand. And if you pull all of those together and do the rating with that, you can get a total of 12 points. And they've identified that if you get a score of 10 or less, this can increase the risk of mobility disability. And so it can help identify those people who are more at risk. Grip strength is another big one, and Bohannon in this article does a review on the information that has been out there in research as to the biomarkers of grip strength. So it can tell us a lot about general strength, bone mineral density, fractures and falls, nutritional status. You can see the list there. It can give us a lot of information. And if you think about it, our grip strength is involved with a lot of the daily functional activities that we do every day. So we wake up in the morning and we're getting our coffee ready and we're lifting and grabbing our coffee maker and pouring, and even those tasks throughout the day, like laundry, we're picking up the basket. So the more we do with those ADLs, the more we're using our hands and our grip. So it's a strong indicator of that mobility. But I do recommend including this with a lower extremity strength assessment as well, just because it'll give you a more thorough look at the whole picture. And then I included the 2-minute step test as well, especially if you are working with a person who may have an endurance component that is impaired. And so this is a 2-minute step test, very easy to do. Takes 2 minutes and they just step in place. You count the number of leg raises on just one leg, and that will tell you, give you some comparisons to age-based norms. And then you can look at the rate of perceived exertion, how much work that was for them. And then the multi-complexity portion of it, we're going to look at their medical status, because a person with very early diagnosis of maybe we'll say heart failure is going to look very different than someone later on in the later stages. And so we need to know where they're at. Is it acute or are things stabilized? And that will tell us how much we need to monitor. Of course, other comorbidities we're going to look at, the environment. So where they are with their physical activity, it can really affect how much or how little they do. Their social supports. So asking those questions, because if we look back to what matters, is social engagement very important to them, or maybe it's not. And so that will affect which way we go with our recommendations. Economic stability, because those basic needs, if they're not being met, is going to impact how important the mobility aspect is to them. And availability of resources. So if we're recommending a certain type of exercise that requires equipment, do they have the availability or access to that? Or do we need to find options that are more home-based? And ultimately, who's responsible for looking at the multi-complexity side of it? And I really argue everyone, because it takes a team. If you identify an area that they maybe need a few more resources, we definitely need to reach out to our interdisciplinary team. Okay, so we're going to look at these 5 M's within the context of a case. This case comes from a geriatric case application within physical therapy practice, but I think since we're talking about mobility, it's very applicable. So it's a patient who was released from the hospital, and he was there for 5 days with a diagnosis of acute congestive heart failure. He's 60 years old, Caucasian male with comorbidities of hypertension, coronary artery disease, diabetes, and obesity. He lives alone in a small single-story home and works as an accountant and wants to return to work as soon as possible. He does not smoke or drink, but his physician wants him started on an exercise program. So we're actually going to take 2 different directions just to highlight the difference that you might see with a patient after your initial questioning. So we'll start with example A. So this is that algorithm that we're first assessing their physical activity. So we ask him, you know, he just got home from the hospital, so he's probably not doing his normal routine, but just to get an idea of what he did prior to this hospitalization, kind of see what his normal activity was. We ask him what that is, and he's an accountant, so he would walk every day at lunch just for 10 minutes. It's a big building he works in, and he would walk around the building just to get up and out of his office. But it wasn't a brisk walk, it was a very slow-paced walk, and he might stop and talk to others along the way. Now, this is great. I would really want to emphasize the importance of what he's doing, because that is something. But it does not meet those recommendations of the 150 minutes of moderate activity. So we'd say 0 there. He doesn't do any strengthening. He doesn't do any balance as well. So we're that's where we're at right now. If we go down then to the readiness to change. So we ask him, does he intend to change in the next 6 months, or in the next month first? We ask that short-term intent. What if he says no? He just got home from the hospital. He's like, why would I do anything new when I just had this hospitalization? And then you ask, well, what about in the next 6 months? We'll give you some time to recover. Would you change down the line? And he might say no. So this really puts us all the way down to the pre-contemplation level of change. So he really has not thought about it. He does not intend to change anything. So if we give him recommendations and say, this is what you should do, and we don't do anything else, it's not gonna take, it's not gonna get anywhere. And so what's our first step? If you think about, if you were in this situation, you hadn't thought about it, probably where we would want to start with is, like I said, validate him at where he's at right now. And that is, you know, incorporating whatever activity he can, but also validate that I understand that you're at that point where you're not ready to change, and you may not be ready in the next 6 months. But some of the recommendations would be to provide some of that education on the benefits of physical activity. I think it's important to never assume that people understand how the physical activity can impact their overall health, because everybody can be at a different level. So providing that education, and then educating on how you, or so myself as a physical therapist or any other health provider, can help them make that change. So education is really key within this pre-contemplation stage. And one thing to consider is incorporating some motivational interviewing techniques. These were some of the techniques that they utilized within that Coach to Move article I talked about. And this Miller and Rolnick, they do have a motivational interviewing book. So if you're interested in learning more, I'd recommend that. But again, it really is more of that facilitating and guiding communication. Learning how to be a good listener as a healthcare provider, I think, is very important, and empowering the person. And so it might be that with this patient, where they're at this level, it's just the goal is maybe just the education. And it's not that we won't go for, if it's myself as a physical therapist, it's not that we aren't going to do a care plan, but it's that our focus is really going to be on the education aspect as we are having them participate in some of the activity while they're there, and moving them towards that mindset of possibly being able to change. So then if we take the same patient and we're just gonna give a different example. So instead of, so he gives us the same information about his physical activity, but when we ask him about if he's ready to change, he says, yes, in the next month, I'm ready. Maybe this hospitalization was a wake-up call for him, and he realized that he needs to make a change. But then you ask him if he has a plan, and he says no. So that's definitely where we can step in and help facilitate that. So this identifies him at the contemplation or preparation stage. So he's definitely thinking about it, but he needs some guidance with that. So we'll talk about including the 5 M's with that mobility plan here. So when we think about the mind for this patient, he's an accountant, so he's working, he's living independently, he lives alone. So what comes to mind with some of those screenings that we talked about? I'll give you a few seconds to think about that. So one thing that comes to mind, you know, we in our subjective assessment, we'll look at the orientation, and he's doing well with that. But he did, and he also has intact vision and hearing, because that's important to our cognition. We do a quick screen just to be sure that everything looks good there with the mini cog. So this one, if you're not familiar with, it's asking, giving 3 words to remember, asking if they remember that a few minutes later. And so that's looking at short-term memory. And then it's taking the clock and doing the drawing of the clock. So they can get a 5 out of 5 is a good score for that. And so he does well with that. But one other thing I would do with him is actually the PHQ. And so he answers that he has had some days of, several days of little interest and also feeling down. And so he gets a score of a 2 out of 6, which less than a 3 is good. Anything more than that, we would definitely want to do further assessment. But it's something, you know, there's something there, but he did just have an acute hospital stay, and maybe a big change in how his physical status and his health status is. So it can affect a person. So it's something we'll keep in mind to monitor as we work with him. When we look at medications with this patient, he's on Lasix, Altase, Aldactone. These are some of the medications related to the heart failure. And I think the biggest take-home point here with mobility is those side effects that can happen, especially with lightheadedness, blood pressure changes, and because we may not want to be doing a lot of change in movement, but it would be something that we would need to assess. And then if we look at the ACE inhibitors, this is on the stop criteria. That's the one I referenced here, but if their potassium is high, we would want to be working closely with the doctor on that. So just keeping an eye there on some labs. And some other medications he's on because of the diabetes, we have the metformin and then the baby aspirin. So with the metformin, again, keeping in close contact with the doctor just about renal function there. And then if we look at our mobility aspects, kind of finding out where he is. So this is the short physical performance battery, and we have him do these balance assessments. He scores a 1 point. He does well with feet together, with semi-tandem, he does well, but when he goes to put one foot in front of the other tandem, that's where he has a little imbalance. And we might find with our assessment with the diabetes, maybe he has a little bit of neuropathy as well. But the 3-meter walk here, he took a little bit longer to do that. So he only gets 3 out of 4 points. And then the chair stand. So we have him do up, standing up, sitting down to look at lower extremity strength. And he only gets 2 out of 4 points. And I do have a reference for the short physical performance battery and how to grade that. But for him, he scores a 7 out of 12, which if you remember back when I talked about it, anything 10 or less does increase the risk of mobility disability. So that's these are definitely aspects that we want to improve with him, looking especially at lower extremity strength. And then balance were the two kind of big points here. So when we look at the 2-minute step test for him, he does only 48 steps. And so for his age-based norm of for a 60-year-old male, this should be closer to 106. So he's very lacking in this aspect of endurance. And if we look at we do want to look at vitals both before and after to look at his cardiovascular tolerance. And so his heart rate actually does not change a lot. His respiratory rate does go up. We're looking at a forearm blood pressure because he does have some obesity. So actually checking for his blood pressure, we need to use the forearm. And just remembering that that will be a higher number than you would get with your upper arm blood pressure. So before and after, we get about 16 in systolic change and only 2 in diastolic increase. So within normal there. His SpO2 is good. But if we look down at his rate of perceived exertion here, at rest even, he's at a 2. So really at rest, we should be a 1 or less. So even just carrying on a conversation or doing very light activity is what he feels like at rest. And this goes significantly up with his activity up into this very hard range. So even though this is just a 2-minute step, this is a lot of work for him, and I think really where we'd want to focus for him. And then if we look at the grip assessment, he measures at 75 pounds on the right, 72 on the left. And if you look at some of the age-based norms for him, he's within 1 standard deviation of that, but he's definitely below the mark for both. So I would say I in physical therapy, and I'm not specifically focused on just doing like hand grip strengthening, but I'm definitely going to incorporate activities where he's doing some grabbing, pulling, lifting with his hands and his arms, more of that multi-component exercise movement to help improve that. And then the multi-complexity. So we're going to look at all of these different areas. For him, he's acute congestive heart failure, but he is now medically managed and stable. I think one of the important pieces, especially with home health, is that we make sure that he maintains that. And looking at his other comorbidities, his environment, he lives alone. Social support, he does have siblings in the area, but he can call for assist. His economic stability, he's working as an accountant, but he is worried about being able to keep up with his job due to the illness. So this is actually one of the things that we identify with him that is something that matters to him. So incorporating that in our behavior change conversations is important. And then he has resources available, but he's not he'd rather do things at home than go out and about. But there's other components of the multi-complexity aspect. So he doesn't have pain, but he does have the obesity aspect, which we need to think about when we're developing our exercises. The other thing is the dietary restrictions. So I think he mentions that the nurse told him he needs to eat better. And so maybe in that aspect, he's recognizing he maybe needs a change. And so if I hear something like that, maybe he does need a little more guidance in that area. So giving that referral as needed. And then we're going to want to pay close attention to oscillating lung sounds, be sure nothing is changing. Also heart sounds, watching the edema, and even the skin, making sure there's no open areas, and sensation, monitoring that. So I don't want to go too in depth, but because of how he was with his 2-minute step test, we really have to start at the very minimum. So right about that 40%. So target heart rate would be 121. And with our older adults, this Karvanen's formula is going to be much more accurate. But I think that one aspect we really want to focus on for him is the rate of perceived exertion. So we'd want to shoot for that 4 out of 10 and then gradually improve from that. But what matters to him is, he loves the outdoors. So we really want to encourage that. And depending on where he lives, try to help him engage in those activities so it's more meaningful to him. And then strengthening, I'm gonna run through this a little bit quick here. But the ultimate goal is that 80% effort of a 1 repetition max, which we have to be sure that they're getting that level of intensity. So if they're able to do more than 10 repetitions and they're not tired with it, it's probably not the resistance that they need. So trying to bump that up just a little bit more. And you can use this calculator here to help figure out what that resistance would be. And so for him, maybe he's able to do sit to stand, and that's important to him because he's noticing that that's getting harder to get out of his office chair. But maybe initially he needs to use his arms a little bit. So that's the modified part. And he's able to do 10 reps, but no more. So that's the right amount, and 2 to 3 sets there. The other thing to do would be a farmer's carry. So this would be holding a weight at his side and either stepping in place or walking. And we can really relate this back to function, like carrying groceries. And so making that whatever is important to your patient and finding that functional activity. But I really want to emphasize we want to avoid the trap of one rep max living. And what that is so many of our older adults, if you think about when they go to stand from a chair, that's that's all they can do. And if you don't have the capacity to do more than that, just one repetition, um, that one medical event can really set you back a significant amount. So we really have to get ahead of the game and build that capacity for our older adults. So this is that idea of functional strengthening. And even in the home, you can incorporate things like carrying a bag, and getting creative with our strengthening activities. So if you try to think of some other functional strengthening, um, these are some things that come to mind, even carrying a laundry basket, and you can grade it with how many clothes are in it. Doing an overhead press, reaching up to the cupboard, or maybe they have to lift a basket into the closet. And a Turkish get up. So this is where you can do this with or without weight, but even just pressing that, starting on your back and doing those full body movements to practice that getting up from the ground. Now, I did put yoga here, but I mentioned he's not really a out and social kind of activity person, but I just wanted to mention that they do have online versions. So if he's a tech person, he could participate in these activities online and or helping him find ways that are more home-based. But the monitoring checklist, I just want to emphasize, this is the monitoring of the multi-complexity aspects. So we want to be sure, since he has diabetes, that we're watching his blood sugar level before we exercise. So that's not a factor. Looking at the intensity levels so that we are getting the adequate amount. We're going to be monitoring for any of those adverse or side effects from the medications, and modifying our activity if we need to. With his comorbidities of the heart failure, we do want to see if there's any significant changes in weight. Also, the auscultation of heart and lungs, looking at any dehydration. That was one of our risk factors with the medications. And then just doing a check-in fairly regularly just to see where they're at with their interests and their mood, and being sure that there are no significant changes there. So this is our role initially, but I think it's also where we need to do our education for our patient and the person we're working on that mobility plan with, so they know how to do that self-monitoring, because that's a piece of that long-term change. And then we can't forget the most important part is reinforcing that behavior change. So doing things like helping the patient to develop the goals that are important to them and really breaking it down, not just having these really big goals. Setting a schedule, or finding what works for the patient. Maybe a schedule, maybe a plan, maybe having somebody to be involved with the activity with them. So finding that way to stay accountable, what will make the difference for them. So asking questions there. And then once you've made the plan, how confident do they feel in their ability to do this? So if the plan doesn't feel very doable, that's going to affect their adherence as well. And maybe you need to go back and modify a few things or add things in. And then we identified maybe the dietary could be important as well, and that would definitely impact his mobility. So do we need a referral there to help guide that behavior change? Or has he been able to make that on his own? And then finally, just like with the other case example, motivational interviewing throughout is just as important here. So empowering them, motivating them to work through that process of behavior change. So, and at this point, it's really just trying to get that activity started, monitor that multi-complexity aspect, education on that self-assessment, so that they are able to get into that maintenance action and then maintenance stage of change. So these are the references.